morning, everybody. Thank you for staying until the end. I know that it's Sunday, it's a gorgeous weather outside, but thank you so much. Let's go and finish the symposium with this case. We'll wrap up. Let me see. So we have a 46-year-old male, no past medical history. He was playing with his son at the pool of his house. He was feeling bad. He went inside to his house, talked to his wife, and he syncopized. No prior history, no prior events. He was taken to emergency department, and basically the workup showed recurrent ventricular tachycardia, episode of complete heart block. He required cardioversions. He required medical therapy. EP was involved. They have to support this patient. However, also they found positive troponins. The coronary angiogram showed no coronary artery disease. However, they found elevated filling pressures with a very low cardiac index and cardiac output. The patient required mechanical circulatory support. He was a non-responder to the balloon pump because metabolic derangement and worsening clinical status, the mechanical circulatory support was upgraded to Impella. However, on top of this support, the patient required escalation of vasopressors and inotropic support, and immediately this hospital, it's in a small city close to us, they contact Memorial Hermann, and our transfer center was called. I was on call. I was walking toward the cath lab, and I got a call from the transfer center to discuss this patient. In summary, we have a young male with normal functional class prior to this event, normal end organ function prior to the event, and now he's on severe refractory cardiogenic shock. I just went immediately to look for my team. They were busy working there, and we activate our ECMO team, our mobile ECMO team. So time is money, and we know that early intervention improves outcomes. We know that this patient already had mechanical circulatory support and full support for vasopressors and inotropic support, but he's not doing well. We had to do something. 210 miles from our institution. It's in Corpus Christi. However, we sent our ECMO team. This is the kind of practice that we are trying to do on a daily basis. This is the record from our live flight. This is the report. I got the call around 10 a.m., 10:25, the live flight got activated. We dispatched our team, and they arrived to ICU at 4 p.m. 2 p.m. The patient was at Memorial Hermann. We brought the patient at 4 p.m. They 210 miles from our institution. When we got the patient, we found this young male with a multi-organ failure, severe refractory cardiogenic shock, respiratory failure, shock liver, acute kidney failure, coagulopathy, severe metabolic derangement, on mechanical ventilation, on mechanical circulatory support, requiring renal support. Sounds familiar? Complex case. Daily base. Drips. Dopa, dobutamine, Levophed, vasopressin, epinephrine, amio, VA ECMO, working. Impella, no problems. But the patient was not doing well. So echocardiogram, biventricular, severely decreased biventricular function. Hemodynamics, on this kind of support, you can see very bad. High filling pressures, very low, poor hemodynamics. Biopsy, severe inflammatory infiltrate, especially T-cell lymphocyte. So our pathology department called florid lymphohistocytic myocarditis, and please consider giant cell myocarditis. They couldn't find the giant cells. Immunohistochemically, basically, this patient had more T cells than B cells and histocytes, myocardial necrosis, and a lot, again, no multi-nucleated giant cells, but a lot of infiltration. So because the concerns, we started immunosuppression, and the patient improved. We were able to wind down all the pressors. We decannulated the ECMO. This was, the call that I got was in May 22nd. We decannulated the ECMO, decannulated the Impella, all the metabolic parameters improved, the inotropic and vasopressor support went off, and he was discharged at the end for rehab due to the condition. So ejection fraction improved. This is a follow echocardiogram after discharge. Hemodynamics in no support after discharge. And biopsy, a lot of fibrosis, but no inflammation. So our daily commitment is to improve the care of our patients. Our daily effort is to improve our inside and outside protocols. We are working with our institutions, referral institutions right now. So we try to follow the effort, national and worldwide effort in cardiogenic shock. We would like to have a clear and transparent and efficient relation with our not cardiogenic shock centers. We would like to activate our teams and all the resources to offer the best care for our patients, to bring the patients to the cardiogenic shock centers. At the end, not always we have a successful history, but at least in this complicated patient, we were able to send patient for acute rehab, inpatient rehab, and now the patient is at home. So learning points, early recognition of cardiogenic shock is critical. Management, but not only in our institution, shock center institution, in our referral centers, small hospitals in the small towns, no cardiogenic shock centers, even no PCI capable centers. If we have clear protocol for management after early recognition, that is the key. We have to have clear plans for transfer, clear commitment, clear protocols for initial therapy, transfer, and follow-up. We need to recognize, we need to be sure that we recognize early the cardiogenic shock to be able to stop the cardiogenic shock spiral. Obviously, we need clear relation with our institutions. We need all the multidisciplinary teams and interdisciplinary interaction, not only with the super specialties in cardiologists, also with surgeons, other medical teams, and all the ancillary services. Thank you so much.
Thank you, Carlos. Any comments? Obviously, this case again highlights the time is critical. You cannot overemphasize that. Then time from the initial time the patient presents till the time it gets definitive therapy, and thereafter, you have to have a well-oiled machine. You can't start, like they say, you cannot start repairing an airplane while it's flying. The plane has to be ready, and you should be ready to fly. Edward, any comments?
I mean, I just want to, again, Dr. Banayosi's not here. He would be extremely proud of this case. I can't tell you how difficult it is. You know, he's in Oklahoma where the need is huge given the disparate area. In my region in Philadelphia, shock teams are just coming into light because of overwhelmingly, very strong surgical mentality to say, do we really want to open the Pandora's box? You have to. It's multidisciplinary. If you have the surgical teams only in charge of ECMO, for reasons that before may have been needed for safety, but now the ECMO devices are just too good. The deployment, God willing, will show safety in most operators. But I just want to congratulate you in having this guy with, I guess everybody agrees, fulminant myocarditis, just an extreme case of just, refractory SIRS and everything. So one question is, was this patient cannulated by your team there, or was he already cannulated? You cannulated him.
Yeah, we sent.
Well, I got you. Okay. I mean, that's why you sent him. I just didn't know if it was just. I wasn't clear if he was hypotensive despite the ECMO, which he was for a little bit as he was getting out of shock, or if you went there because what else can they do? These are VA ECMO all pressors.
Let me tell you the history. The attending who cannulated the patient, he told me once the helicopter was landing in Corpus Christi, 210 miles from here, the patient was arrested. He was arrested on the table, and they cannulated the patient. Our team cannulated the patient just starting the resuscitation.
Yeah, we are doing similar stuff in Hamburg. We are also going out to get the patient. That we ask sometimes actually the other hospital to put some small 6 French sheets in already to be a little bit faster if there's arrest. So then it gets really messy with the ECMO, and that sometimes just saves like 10 minutes or so. Yeah, if they just have the cheese, then.
No, that way, we are very proud to have a very good life flight system, one of the best life flight systems in the country. Their safety record is so good, and I think all of them except one are ex-combat pilots, so they fly under any weather conditions at any time, and they're just superb. And that's why we've been able to save a lot of lives around. Any other questions?
May I comment? Just here, just one point on the quality of the hub and spoke. I mean, this can work only if the remote centers have some minimal quality so that you can trust the people there. I mean, you decided to fly there because you knew that the people there were, let's say, right in what they say. You don't have any doubt on what they say and so on and so on. I think that this minimal quality needs to be really assessed. So, I mean, it's a little bit a mixture between a network and hub and spoke, because if you are dealing with some people you don't know exactly what they say, it's much more complicated when you have to send even an ambulance with your ECMO team and so on. So it's very important to have really good collaborations, and that indeed you know who is on the phone on the other hand.
Can I say one thing in response to that? It's interesting because he's absolutely right, but we know that, number one, dynamic changes occur. You probably took the call, and the number one thing that probably made you say, we got to get out there is 46-year-old with no prior history. You know that's a survivor. Yeah. And I couldn't agree with you more. I mean, I'm on the phone a lot with these great docs, but, you know, they want these patients to get out of there because they know they're going to die there. So it's a really tough balance, and, you know, I wish Ali was here because he's just made his whole career on determining if he's going to fly a whole team out there in the middle of a tornado or not, you know. By the way, just one comment to Biswajit's great course, great conference. Biswajit, you know, this is Texas, and I trained here, so I know how competitive the Texans are. I just want to point out that 5 out of the 8 case presenters were from Kansas. I'm from Ohio, but I'm just saying, great job, Jayhawks.